Yeah, good evening everyone. So today we will be discussing about approach to glomerular diseases. Approach to glomerular diseases. So basically we will be discussing on a basis of it's four examples actually. So first will be of a glomerular pathology nephrotic syndrome, under which we will be discussing about the syndrome per se and nephrotic range proteinuria. Then we will be discussing about nephritic syndrome. Then we will be discussing about IgA nephropathy. Not actually, I mean, a case scenario, simple case scenario. Then we will be discussing about RPGA. Okay. So this is how we will be approaching the pathologist per se. So first we will discuss about the classical nephrotic syndrome per se. So what is called nephrotic syndrome? So nephrotic syndrome is nothing but a nephrotic range proteinuria. What is nephrotic range proteinuria? Nephrotic range proteinuria is greater than 3.5 gram per day. Okay. So basically nephrotic range proteinuria, which is leading to edema plus hypoalbuminemia plus hyperlipidemia, hyperlipidemia plus hyperlipiduria. So this entire complex is known as nephrotic syndrome. So basically, I have seen people who are saying like the protein, the 24-hour protein, urinary protein is 3.5 grams. So this nephrotic syndrome. So it's nothing like that. So it's nephrotic range proteinuria with edema, nephrotic range proteinuria or nephrotic range proteinuria that is leading to hypoalbuminemia, which is leading to reduced lung pressure that is resulting in edema, which also is accompanied by hyperlipidemia and hyperlipiduria. So the entire complex, if everything is present, you can call it as nephrotic syndrome. Okay, so that is nephrotic syndrome. So in nephrotic syndrome, so basically, it can in a child presenting with nephrotic syndrome, it's never you can never miss a patient. Presenting with nephrotic syndrome. So classically, they will present with facial puffiness and generalized anasarca, facial puffiness, especially periorbital edema, and generalized anasarca, generalized anasarca with a normal RFT and nephrotic range proteinuria So it's easy. It's very unlikely to miss a child, but it's very unlikely to miss a child who is presenting with nephrotic syndrome. But it's not with that case of adult onset nephrotic syndrome. So adult onset nephrotic syndrome actually it can be confused with malabsorption syndromes. So basically, the patient will be presenting with a catabolic in a catabolic state, very thin, lean patient with central obesity or central edema presenting with proteinuria, we might think of malabsorption. We might be mostly thinking of malabsorption in that case. But this patient could turn out to be a patient of adult onset nephrotic syndrome. Okay, so adult onset nephrotic syndrome, then child, okay, and in nephrotic syndrome in elderly. So in nephrotic syndrome, the most common cause of nephrotic syndrome in children is minimal change disease greater than FSGS greater than membranous nephropathy. So it is minimal change disease greater than focal segment glomerular sclerosis and greater than membranous nephropathy. So what exactly happens in minimal change disease? So in minimal change disease, there is podocyte effacement. So this is the Bowman's capsule. So this is the glomerular tuft. This is the glomerular tuft. So there is podocytes. So basically, these are the slits present through which the filtrate get filtered, ultrafiltrate get filtered into the Bowman's capsule. So basically, they will be having this negative charge. Okay. So in minimal change, what will happen is there will be effacement of this podocyte. So the effacement of this podocyte will result in the loss of negative charge. Effacement will result in the loss of negative charge. So so the negatively charged albumin, which is relatively it's a albumin is a high molecular weight protein, but the diameter is bit small. Okay, so basically it's a charge. Basically, albumin is getting prevented by from filtration due to this negative charge. Okay, so when the podocyte get effaced, the charge of the glomerular, the charge of the podocyte is lost. So this will result in the negatively charged albumin getting filtered through the tubules. So that is what is happening in minimal change disease. So in FSGS, so that is what is happening in minimal change disease. So in adult onset nephrotic syndrome, it can be due to FSGS greater than membranous nephropathy. In elderly males, it can be due to mostly membranous nephropathy. It could be secondary due to multiple myeloma or other causes as well. So, okay, adult onset nephrotic syndrome, childhood nephrotic syndrome, and in nephrotic syndrome in elderly. So, having discussed about nephrotic syndrome, now we'll go to the classical nephritic syndrome. So, in nephritic syndrome, it will be how will a patient of nephritic syndrome present to us? So, a patient presenting with proteinuria, with hematuria, proteinuria with hematuria, we have to with elevated or normal or borderline BP, elevated or borderline BP, borderline blood pressure, you have to think of nephritic syndrome. So basically, as we have already discussed in our previous videos, so how will you assess glomerular hematuria? So what are the characteristics findings in glomerular hematuria? Hematuria can very well be due to a post-renal cause. So how will you say it's a glomerular hematuria? So you'll be having the 40-5-1 rule. So what is 40-5-1 rule? 40 is percentage of dysmorphic RBC, 5% of acanthocytes, or even one single RBC cast. So if it is present, it is a glomerular hematuria. So glomerular hematuria with proteinuria, with loss of protein inside the loss of protein from the kidneys, it indicates suggestive of nephritic syndrome. Okay, along with an borderly raised BP, or can also present with oliguria, plus or minus oliguria, plus or minus oliguria. Okay, so this is how a patient of nephritic syndrome can present to us with. So third one is a patient who is having high colored urine, high colored urine with the glomerular hematuria with or without proteinuria, or without proteinuria. Can be I could be IgA nephropathy. IgA nephropathy. So now we will discuss about the most important clinical scenario of this of this glomerular pathologies. So basically, consider a 28-year-old female who is presenting is referred to you from a local GH with periorbital edema, with pedal edema, with increased JVP, and the patient is doesn't complain of any breathlessness, no complaint of breathlessness, no complaint of breathlessness or palpitation or palpitations or any gastritis. So the patient is having this history over the past 2 to 3 weeks. Before 3 weeks, she has been perfectly all right, and over the 3 weeks, she is complaining of oliguria. Over the 3 weeks, she is complaining of oliguria. Okay, you run the baseline RFT. You run the baseline RFT. Now the patient's renal output is nil. Renal output is nil. Renal output is nil. So you run the baseline RFT. Urea is 120, 120. Creatinine is 5. So how will you approach this patient? So basically this patient has underwent a renal failure. So basically this patient has underwent a renal failure over past 2 to 3 weeks or in a 2 to 4 weeks. So this is nothing but simply put into the picture, it is nothing but rapidly progressive renal failure. Rapidly progressive renal failure. So basically, what are so you should always in the nephrology. So we almost always deals with CKDs. So it's okay. So in CKD, no matter what we do, there is nothing we can do much to the patient. I mean, unless otherwise the patient takes a renal transplant, there is nothing much we can do. So this is nothing like that. This is rapid progressive renal failure. So in this case, it is time is gold and time is gold, platinum and everything. So basically, rapidly progressive renal failure. If you are not acting on time, the patient can very well progress to CKD. So once it progresses to CKD, there is nothing again much we can do. So so basically, finding it in the early stages can save the patient's kidneys. So basically, rapidly progressive renal failure. So how can we proceed further with this case? So this can very well be due to a pathology of the glomerular compartment, vascular compartment, and tubular compartment, tubulo-interstitial compartment. So what makes you think this patient belongs to the this patient is having a pathology related to glomerular compartment? Proteinuria with edema, proteinuria with pedal edema, along with in, along with normal or mildly elevated blood pressure. So basically, volume overload. The patient is mildly oliguric. The patient is oliguric with elevated JVP, and the patient is having periorbital. The main key component is periorbital pedal edema with rapidly progressive renal failure. We can compartmentalize it to glomerular compartment. So what in the glomerular compartment can cause RPRF? So it is nothing but our rapidly progressive glomerular nephritis RPGN, which is further classified into type 1, type 2 and type 3. Okay. So from vascular compartment, what can cause rapidly progressive renal failure? HUS, hemolytic uremic syndrome. But in hemolytic uremic syndrome, the patient won't be having a high history of high colored urine. Okay. They can cause microscopic hematuria, but very unlikely to cause a gross hematuria or gross high colored urine. So the next compartment is tubulointerstitial compartment, where the patient will be having, which is caused, where the most common cause is acute tubulointerstitial nephritis, where the urine analysis will be showing granular cast. So now we will be discussing about RPGN type 1, type 2 and type 3. Of which type 4 and type 5 is also there, but most commonly type 1, type 2, type 3. So type 3 is the POSI immune variant. So if you do immunofluorescence, it won't be showing much fluorescent areas. The fluorescent areas will be less. So it is called POSI immune. So it is mostly associated with vasculitis. So what are the vasculitis which you know to cause renal involvement? Venous granulomatosis, venous venous granulomatosis, where it is Canga positivity, or Chuxos, where it is Pianga, and it will be having signs of peripheral eosinophilia as well. Peripheral eosinophilia as well. So basically, Chuxos, weakness, basically small vessel vasculitis are most commonly associated with post-immune type 3 RPGN. So type 1 and type 2. Type 1 is anti-GBM antibodies. which could be IgG and associated with C3 deposition over the glomerular basement membrane. The immunofluorescence will be showing linear pattern. Okay, and coming to type 2 is mediated by immune complex deposition, which could be secondary to SLE